going to speak about something that we've been working a lot with the spine surgery folks as well, which has been how to diagnose and maybe try to find some biomarkers for identifying traumatic injuries of the craniocervical junction. So we've basically split the talk in trauma and non-trauma. So we're going to be doing some of the traumatic injuries today and some of the anatomy as well. And of course, this poses a lot of, as you're going to see at the end, a lot of things that have still not, we're still not really clear what a lot of the lesions mean. But we're working very hard to try to see if we can identify biomarkers with prognosis. And I think we've done that. Yeah.
How come your NDA is not there?
It's not for this part. I have to put it, I have to update
That
that.
should be your disclosure.
So first we're gonna just check the anatomy, and then we're gonna check out what the imaging techniques are. And when you ask for a craniocervical junction, why is it different than when we just do a regular image? And I'm gonna show you some injuries and how we are reading them and how we can help you guys make decisions when you're doing your surgical planning. So one of the problems with the craniocervical junction is that it's one of these no man lands, right? We really don't scan for it because it's kind of, you either do a cranium and a skull base, but you never actually do this junction per se. So when you're not doing the junction per se, it's really complicated to really understand how to scan it and how to look for the injuries. But it's in the middle of two regions and two regions that we scan frequently, which are the head and the neck. So this is pretty easy for you guys. Of course, there are three bones, and the occiput participates with the occipital condyles, and it articulates with the atlas and then with the axis. So now we have, when we study this, you're going to see we have another no man's land, which is what happens between C2 and C3, because that is something that we will have to cover and we'll cover definitely. So these two articulate. If this thing works, it didn't articulate as I wanted, but they do articulate. And then we have the joint capsules, which are in blue. Some of the surgery literature of the last 4 years have actually defined that the joint capsules are one of the major stabilizers, especially the atlanto-occipital joint capsules of the craniocervical junction. So this is a diagram that it's kind of complicated when you try to see it. It is one of our chapters that when we started writing about this in 2017, that shows a bunch of ligaments. There's a lot of ligaments, a lot of complex anatomy to it. And I don't think that we should learn the whole anatomy for practical purposes. Maybe for surgical purposes it is, but you usually do not go that deep. Because not all of the ligaments that you're going to see here are actually going to be participating actively in the stability of the craniocervical junction. So this kind of a modified diagram of it, and we're going to see kind of these ligaments as well when we're going through it. And you're going to see from deep to superficial, we're going to be checking out, let me see if I can get this thing going. Yeah. So you're going to see from deep to superficial, the tectorial membrane, which is a continuation of the dura that you have in the clivus, and it's going to go and fuse kind of with the posterior longitudinal ligament. Then posterior to that, you're going to see the cruciform ligament, where the transverse ligament is just part of it. Then you have this little apical ligament that really does not have a huge function in the stability. And finally, anteriorly, you get the anterior atlanto-occipital membrane. Some books have also described the membrane, which is the atlantoaxial membrane here anteriorly, but it hasn't been demonstrated to be very functional. If you just go from behind and you take away the posterior arch of C1 and C2, you're going to kind of see the cruciform ligament. And of the cruciform ligament, more than the superior or the inferior crus, what's really important are the transverse fibers that are going from one lateral mass of the atlas to the other, which are the transverse ligament. And they kind of keep the dents ventrally and isolate the thecal sac posteriorly. And of course, kind of these little arms that you see from the dents going up into the occiput, the occipital condyles, which are the alar ligaments, which are really major stabilizers and they do not allow some of the rotation. And we do pay a lot of attention to them when you have them torn. They tend to, that tends to be a very important sign. So, so let's look at the intrinsic ligaments. And these are the three that we read for you guys. And I think those are the most important ones, which are the tectorial membrane, the odontoid ligaments, and the cruciform ligament, as I just showed them. So this is the tectorial membrane. It's easy to see in the sagittal view. So you really do not need a craniocervical junction to do it. But you can see that the tectorial membrane is this very thin region of fibers that you're seeing right there. And again, it's just a continuation of the dura and it fuses with the posterior longitudinal ligament. And it only gets hurt when you have extremely high impact trauma. And usually it happens when you have a very high hyperextension. But before you tear it out, you have to tear down a lot of the structures that are happening in the prevertebral soft tissues. I'm going to get to that later today.
Is the tectorial membrane continued? Is it part of the dura or is it extradural?
It's a continuation of the clival dura.
But then it becomes the PLL.
It kind of fuses with the PLL. It's connective tissue that just
The
fuses.
PLL is extradural.
It's I guess that's why it's a membrane. Yeah,
That's a kind of seems so.
I guess yeah. Imagine it's kind of part of the periosteum of the intracranial, and that periosteum just goes down connective tissue and then fuses with the posterior longitudinal ligament. It is separate, and I'll show you a case of how it looks separate than the dura downstairs. So in the axial views, we do high resolution images to show you the part of the cruciform ligament that's really important. And here's a view that you're seeing of the transverse ligament. So this is the transverse ligament, goes from one lateral mass of the atlas to the other, from one side to the other. And it kind of encases the dens ventrally, keeps the dens ventrally, and keeps it from going backwards. And if it goes backwards, then it could hurt the structures that you have of the thecal sac that you have right here, right? Some books call it the cruciate ligament. It's more cruciform if you look at the anatomic literature, because it looks like a cross. And it has these superior and inferior extensions, which are not that important. When you see it in imaging in the sagittal view, it's just a thickening just behind the dens. So when you see the dens and you see kind of that little thickening, that is the way to see the transverse ligament. And it usually does not get hurt that way. It gets hurt typically in one of its insertions. And finally, we do very thin sliced coronal views to show you these kind of triangular fan-shaped ligaments that go from the dens into the occipital condyles, which are the alar ligaments. So at the beginning, they didn't pay a lot of attention to the alar ligaments, but of the apical ligaments, which is these three that you have there, the apical plus the two alar, the alars are really restrictors of hyperrotation. So when people do rotation and flexion, they kind of keep it from happening. Another thing that the alar ligaments are so important doing is that because of the alar ligaments, that C2 is attached to the condyles. So it kind of serves to sandwich the whole craniocervical junction in place. So if you get hurt, both of your alar ligaments get hurt, basically the dens can drop and you can widen up the two very important joints, which are the atlanto-occipital and the atlanto-axial joints. So it really serves a bunch of purposes in the stabilization. It has two sets of fibers, a ventral and a posterior. The posterior tend to be a little bit thicker, and I'll show you both today. Of the extrinsic ligaments are not as important in stabilization as they are to understand the mechanism of injury. So anterior, you have the atlanto-occipital membrane, and posteriorly outside, you get the nuchal ligament. And the nuchal ligament is just kind of a continuation of that interspinous ligament when you get to the occiput. So if you get things that get hurt dorsally, usually these are hyperflexion injuries. If you have things that are these ligaments or soft tissues get hurt ventrally, is because it's a hyperextension injury. So these are graphs of the joints. And evaluating the joint is something that we're still trying to do better. I think we do it better than most of the places that are doing this because we do this very high resolution. But when you have a little bit of injury of the alar ligaments, like here, you can see this widening of the atlantoaxial and atlanto-occipital joints. When they get widened, typically you're going to see these pockets of fluid when they're full of fluid. And if the pockets of fluid are there, usually it's because they're intact. When they get completely torn, you will not be able to see these two pockets of fluids. And when we don't see that, usually you see fluid in the stir around the joint, and we say that they were torn. And these guys are very, very important for the stabilization, especially the atlanto-occipital. Since the atlantoaxial has so much movement, it really is not a huge stabilizer.
Is that picture showing intact alar ligaments?
They're disrupted. They're very high resolution. They're partially injured. I'll show you. I've got examples of the whole thing. These are partially injured alar ligaments. So let's talk about the joints. So the atlantoaxial joints and atlanto-occipital joints, they look similar in imaging, but they're completely different, right? If you try to do lateral flexion, you see that both ligaments will impede lateral flexion. You cannot just do lateral flexion of the craniocervical junction. They allow you to do anterior posterior motion, flexion and extension of the head, and to do rotation, but they're very good to not allow the lateral flexion of the craniocervical junction. So what are the major stabilizers? The joint capsules, the transverse ligament, and the alar ligaments are the most important biomechanical stabilizers. And the tectorial membrane is just to see if there's a big injury, we need to really see it. And so that's why we do all three planes when we do that. So let's talk first about flexion and extension. So these are graphs in 3D of how flexion and extension happens, and you see the vectors where they happen. So most of the flexion and extension happens in the occipital condyle in the superior aspect of the lateral mass of the atlas. We have most of the range of motion in that joint. We have very, very little motion in the atlantoaxial joint. So a flexion and extension joint is actually the atlanto-occipital joint. Well, the rotation is done at the atlas and the axis. And most of the rotation is done initially independent. So they can move independently around 23 degrees, right? Once you have a much bigger range of motion, they can go up to 65 degrees just within the joint. And this is very, very important. So when you have almost 65 degrees of motion within a joint, it is very easy to see denuding of a joint when the patient has his head positioned laterally. And this has allowed a lot of people to falsely call rotational dislocation of the atlantoaxial joint. And it's just that the position of the head is in the wrong place. So naturally, they have a lot of displacement to allow the rotation. And then it's only after you go from 65 to 90 degrees that you actually have a motion of C2 to help out with that rotation. So safely have at least 45-degree rotation within the atlas and the axis. And that's why that joint is not as much as a stabilizer, because it is a joint that moves the most in the body, and it gets really denuded in the imaging. So this is one of the papers from your journals. This comes from 2019, just before the pandemic, showing how the occipital atlantal capsular ligaments are primary stabilizers of the craniocervical junction. And this is, even though it just looks like a little paper, it really was, people were not taking that very seriously. We were not trying to identify if the capsules were there or not as major stabilizers. So let's now look at images. So this is kind of what the literature shows. And one of the biggest problems we have in the United States is that the number of cervical injuries is just increasing. This was up to 2013 in this paper from another group, and they were seeing the increase. And we did a retrospective analysis of 5 years here, just with our population, and this tendency keeps on growing. So cervical injury, at least at our shop, is still increasing. I won't get to why, but motor vehicle accidents, people driving intoxicated, they have a lot to do with it. Most of the injuries that you can see in the cervical spine, the bad injuries, happen at C1 and C2. This is where you get the vertebral fractures. Below C2, the fractures are a little bit high towards the lower cervical spine. So we imaged 13,000 patients, and of these 13,000 patients, almost 1,000 came to level 1, and we have a very high incidence of cervical fractures of the whole spine. They may make up around 33%, but a lot of them happen here. We published in Emergency Radiology in 2020. This really is not what happens in a lot of the places in the country that have reported it. And it's possible that because we heliport so many patients, we get a lot of these guys getting here alive than in other places. So I think that we're a very unique place to talk about these circumstances, and that's why we have these data. So we can image through X-ray, CTA, DSA, MR, or CT. So what should we do? So definitely CT is the image of choice. We should always start with the CT. The CT has to be a high resolution CT. We do all of our CTs at 0.625 millimeter slices, which is very thin. We reconstruct them at 1.25, and we reconstruct them in sagittal, coronal, and the axes are already, we also reconstruct them. And that's how you're gonna see them. CT always will give you great, beautiful bony anatomy. So without CT, you wouldn't see this condylar fracture right there, which is very small, that extends all the way down into this part of the condyle. Or you wouldn't, I'm sure you would have seen these pars interarticularis defect of C2 right there. But it also helps you check out some of the soft tissues, even though it's not the best, and start identifying some of the spaces that we use for this. So MR is very important for soft tissue injuries. So we have to concentrate on that. So with any patient that you have that has any sort of neurological problem, they need to have an MRI to exclude soft tissue injuries, basically of the spinal cord. And then you start looking for stabilization, and if the lesion is unstable. A lot of the lesions cannot be, you cannot tell if they're stable just with CT. So you would need, in very high impact injuries, an MRI to look for the ligaments. Also to look for spinal hematomas. We had a couple of very expansive spinal hematomas we have to evacuate. And we do CTA to look for vascular injuries. Every time that you have a craniocervical injury, that's where you have most of the motion of the vertebral arteries coming out in their V3 segment, in and out of the foramen, and that they can get hurt right there. And in any patient that you have a rigid spine, these are ankylosing spondylitis, and any fusion, which is a surgical fusion, dish, OPLL, these patients should have rigid spine MRIs because they tend to get fractured and be unstable much easier. So let's take a look at the literature, and the literature says that MR is very helpful. It is much better at defining the type of spinal cord compression and picking these very unstable small lesions that CT can. So this is what we offer here. We've done axial, coronal, and sagittal thin slices to the craniocervical junction. This is our old protocol. We're right now updating it since we have new magnets. But it takes us to do 2.5 millimeter thickness T2s around 3 minutes each. That's kind of to do both. We stopped doing the sagittals because we could use the sagittals from the C-spine. So it actually only adds 5 minutes. But what we're really trying to see is if we can add a 3D to see much better the ligaments. However, we're not sure the prognostic value is going to be good. And the problem with the long sequence is that the more time you have, the more motion that you're going to have. So this is how this kind of goes to what Spiros was asking. So here's the transverse ligament. You can see it can be like this. These are both normal. As people age, they get thicker. So it's normal to see this is a 50-year-old versus a 14-year-old. You see how the ligament just starts getting more and more connective tissue, and it gets thicker. But you can see it very nicely in all the MRIs. You don't need a lot of high resolution for that. These are the
pointer was
normal.
not showing.
Yep.
Your pointer wasn't showing. Sorry.
Oh, I'm looking at. Let me with this pointer here. Can you see it? Yeah. Okay. Right there. The one, and that's the other one. So going from there to looking at lesions, that's where I want to check, we need to check. So these are the alar ligaments, and now I already showed you the span alar ligaments and how we can see it in high resolution coronals. It's very tough to identify just looking at the joint spaces in the CT. Now, and this is a tectoral membrane, and it also gets thicker with age. This is a 32-year-old, and this is an almost 60-year-old. You see it gets slightly thicker with age. So it's normal to see different thickness of these structures, and they tend to get thicker. So this is kind of new. This is something we only do here, which is doing this 3D proton density sequence that we developed, where we're trying to really look at the ligament. So if you look carefully, you see the dents. And if you look at the dents, you start seeing the first fibers of the alar ligaments. You see it there? Those first fibers then give way to the second set of fibers, which are the thicker fibers of the alar ligament. So that, my friend, is what an alar ligament looks like. And this comes from our magnets here. I wish we could always give you those images, but it's really tough because of motion in the patients that have trauma. But we can definitely see them. They do exist in a way that we can present that images. And the 3D also allows you to evaluate the joint capsules pretty nicely. So this is a sequence that we're trying to but we're gonna use it in some of our trauma patients, but in the 1.5 Tesla magnet, I have not been able to have the same results as the 3 Tesla. So this is one of the projects that we had, which was to put this sequence to assess the craniocervical junction. And we saw that by using the sequence versus not, it's orange versus gray, we could see much better the anatomy, especially of the alar ligaments, and much better the joint capsules. So we can evaluate joint capsules and alar ligaments better with this high resolution 3D coronal proton density that we're doing. It allows better visualization with much higher sensitivity for ligamentous injury, and it was statistically significant. So when we do imaging evaluation, instead of using classifications, I don't think, because there's really not one better than the other, and there's like 32 classifications of craniocervical injury. What I think we should do is to standardize a way to read all the structures that are important to make clinical decisions. And one of the problems with that is that there's not one image modality that will allow it to do it, because CT is so much better at looking at bones, and MRI is so much better at looking at soft tissue. And CT angiograms are so much better at looking at vascular, that to put a classification by using one imaging study is almost impossible. So I think what should happen eventually is that we should have kind of a list of the structures that are important. We have to start giving them some sort of grading of what injury will be tied to the prognosis, and split it into the osseous structures, like the 3 bones we spoke about, C2, which gets its own breaks at the spondylolisthesis and spondylolysis. And then the soft tissues separate, the ligaments, the prevertebral hematomas, the extrinsic ligaments, and the spinal cord. And CTA definitely for vasculature. So it has to be kind of putting everything together to see if you really need to intervene or not. And that's what we're trying to do currently. So let's look at injuries before for the rest of the talk. So the injuries have to be split, as I showed you in the previous graph, into osseous and ligaments. And Dr. Blackburn, here's one where you can see the transverse ligament separate from the thecal sac. See, so you can see some of these things separated from a very thin thecal sac that you have there. So we wrote this paper back in 2015 in one of our main educational journals, which is Radiographics, where we gathered all of the literature that was out there, and that this was kind of how we started putting everything together. So the literature was showing mostly bony injuries, and I think that we're going to write down and one with bony and soft tissue injuries next. But we have classifications of the atlanto-occipital dissociation. There's a classification of the occipital condyle fractures. one of C1 fractures, another of dent fractures, which was actually developed in this hospital, and another of traumatic spondylolysis of the axis. They're completely separate. These are the most used, but there are 32 classifications of this region. So bony classifications, that see the ones that we already are using. So this one is the atlanto-occipital dissociation. You see there are three types: type 1, type 2, and type 3. Type 1 is when the condyle kind of displaces ventrally, so kind of the head moves ventrally from the spine, and you can see the occipital condyle, that's that guy, been displaced from C1. It can happen unilaterally or bilaterally, and that's a type 1 dissociation. There's a vertical dissociation, and when that vertical dissociation happens, typically you're going to have the alar ligaments pulling on pieces of bone from the condyles, and you're going to have these little condyle fractures that we're going to talk about later today. So this is a vertical dissociation, or you have a posterior dissociation, where remember that atlanto-occipital joint should not be moving back and forth. It just allows flexion and extension. So if it moves posteriorly, you can have a type 3. We did a study of those injuries. Dr. McCarthy from our team did it with our researchers and found that here most of the lesions that we had for dissociations were ventral dissociation of the condyle over C1. And then the other two were less. And that doesn't really fit with a lot of the literature. The literature says as a little bit different than us, and they were saying the type 2s and 3s were the most common. And here's where I really believe that when the literature is showing something and we have something different, is because the type of injuries that we see in this place are just more acute. We get them sooner because a lot of these craniocervical junction injuries in other places just die. People get huge injuries and they cannot be stabilized on time. These are the occipital condyle fractures. There are 4 types. There's one that's an occipital fracture that smashes the condyle. One is a little occipital fracture that just is a linear fracture over the condyle. And then the 2 that are traction injuries of the alar ligaments over the condyles can be a big chunk or a little chunk. If it's a little sliver of condyle fracture, these ones tend to heal much less than these. The larger the defect, the more bone you have to heal it. So these can become pretty unstable over time. Here are examples of that. So there's a type 1 fracture, or this is a complete compression fracture with burst of the occipital condyle. You can see the burst of the occipital condyle. That's a type 1. These unless there's something big, they tend to heal pretty nicely. There's a lot of bone in contact with them, right? This is a type 2, which is just this linear fracture. And that linear fracture just has a little extension into the occipital condyle. These are also very stable. And then we come to the ones that are kind of big chunks of the condyle that just get pulled away by traction of the alar ligaments. They can be big, like in this case, or they can be small, like in this case. And these are the ones that heal the least, that there's a big injury in the ligaments when you see them on MRI. You can also have fractures of the atlas, and everybody tends to call the fractures of the atlas Jefferson's fracture. Actually, the Jefferson's fractures are only the burst fracture of the atlas. The others are really not Jefferson fractures. And we divide them kind of, are they in the anterior arch and the posterior arch? And every time that you have an anterior and posterior arch fracture, what happens is that one of the lateral masses of the atlas becomes unstable and it can move laterally. And that's why you get this discrepancy between the typical line that you see in the coronal view between C1 and C2, right? They move along. Now, odontoid fractures, again, this classification was started here. This is the most used classification in craniocervical junction injuries. It's the types of fractures, the tip of the dent, the base of the dents, or the neck of the dents, or when it extends down to the body. This is the one that tends to be more unstable just because you lose the vascularity, and you can have osteonecrosis of the dents, and they tend not to heal as easily. And here you have just examples of those. And traumatic spondylolisthesis of C2, I'm done with classifications after this. These were falsely called all hangman's fractures. So what happens is that the point of the biggest weakness of C2 is in the pars interarticularis. So when you do any hyperextension or flexion, it breaks right there. When that happens, it can be because of two mechanisms. The hangman came because the judicial hangings happened in a hyperextension lesion. When that happened and you broke C2, the two fragments would approach each other and it would constrict the cord, the patient would die. Most of the injuries that we have are because of hyperflexion and the whiplash injury. So even though there are C2 spondylolysis, they're really not hangman's fractures. And what they do is they open up the ring. So these are pretty stable. They're pretty scary to see, but they tend to be very stable. When we read them, what we need to tell you guys first is there any changes between C2 and C3? Is there a translation or not? If there is, then they become a lot more unstable. If there is a translation, or if if the two fragments approach each other, then you can think it was because of hyperextension. You can have hurt the cord and you need an MRI urgently because of that. This was one of our papers of traumatic spondylolisthesis of the atlas. And what we did here, we saw that the most frequent was the type 1, which is the one where you don't have translation of C2 and C3. The type 3 is the least common, and there's a higher rate of vertebral artery injuries in patients that have 2s and 3s. So 2s and 3s typically are associated with vascular injuries. So CTAs, even though in the ER sometimes you sneeze and you get a CTA. Here you really need a CTA, right? This is where we say, please ask for order a CTA.
They don't require sneeze anymore.
No. You know how long it takes to read a CTA? I hope that you're gonna sit with me and say, this CTA, this is without CTA. You're gonna see my life when we do 30 of these because the patient has neck pain, things like that, you know. It's the problem is that there are strokes waiting for us to help them out. So now let's get to the ligaments. You wanted to see the ligaments, not the bones. So we actually do not read the bones here. Most of the bones are read by the musculoskeletal guys in the ER. We get to read the MRIs. So this is kind of what we read. So let's start with the first one, which is the transverse ligament. So it's pretty easy, I think, for the residents to remember. You know, we do an axial, a coronal, and a sagittal. In the axial, you look for the transverse, the coronal for the alars, and in the sagittal, you look for the textural membrane. Not a lot of memory there. So that's normal. I showed it. So let's see abnormal. So this is normal, and that's a tear. So it will look like a high intensity signal. It usually happens in the lateral aspect of the ligament, and it can be complete or incomplete. If it is, tears of the transverse ligament can be or not associated with tears of the annulus of C1. So if C1 is fractured, you can have a C1 isolated or with a tear, or the other way around. Usually when they both are present, it becomes pretty unstable. So when you see a fracture of C1, what you really want to evaluate for C2 to see the stability.
Are you looking at a stir sequence or just proton density?
These are T2s. I only do the
Plain T2.
plain T2. They can separate completely. See this one, you have a complete separation of the fibers. You can have complete separation of the fibers. Or this one that I had shown, which is a complete injury, and you see just a little bit of the dura left, and this is just a lot of fluid in the joint capsule. So you can have all the flavors you want, and we try to describe if there's complete, incomplete, or mostly if there's any retraction of the fibers, and if it's medial or lateral. This is one where you have a burst fracture, Jefferson fracture, and you see that the transverse ligament at its attachment in the lateral mass is gone. So these are the ones that tend to become a lot more unstable.
You can tell on that if that's a ligament injury or if that's the bony fracture.
You can tell.
Like,
Say
are
that
you
again.
able to?
Repeat that.
You're able to tell on that MRI on the right if that's a ligamentous injury or if that's the bone.
I can tell you that the ligament is not attached to a bone. Yeah, that's what I can tell you. But when you look at the CT, what happens is that there's decent upholstery fracture of the condyle right there, of the lateral mass. So that these tend to need repair because they're pretty unstable. Now, alar ligaments, and this kind of, I always thought that we were discovering, you know, America or whatever with this, but then Jessica and Carl tell me that they don't pay as much attention to this, so we will eventually figure it out. So these are the alar ligaments. You see them as these two bands. This is a young patient, and look at this. That's definitely a dissociation of the atlanto-occipital joint, and you see they're completely torn at their condyle attachment. So you can really see them, and you can really see complete tears. This is a bilateral tear, and this patient was pretty unstable. He had other injuries, but it's not a surprise that when you have a dissociation, people cannot go around with a dissociation and be walking, right? So when you have a dissociation, these alar ligaments have to typically be gone. What really happens is that sometimes they're in the collar, and the CT looks normal, and we cannot identify the injuries, and that's where the MRI will really help you out. Because once you take away the collar, you know how stable or unstable these things are going to be. Right? This is a ligamentous injury that happened at the dent. So you see most of the tear. So the tears don't only happen at the condyle aspect; they can also happen at the dens level. And this was the normal. I put it in green there so you could see it. And they also can happen in kids. This was a hyperflexible kid. He was a Mortius, and he had an injury. But we did see in the CT a widening of the space more on the left side of the between the dens and the condyle. And lo and behold, he had a complete injury of the alar ligament left side. So are we missing injuries just by doing the 2.5? So this was the MRI that we had, and we saw some high signal in that alar ligament, and we didn't know if it was really injured or not. And I guess at least for us, that's where the high resolution sequence really helps out. So this is the same patient in our very high resolution sequence, and you can see that there's a chunk of the ligament that has been torn, which is the inferior part of it. And you can see it there as well. So some of the anterior and the posterior fibers were gone. It was almost impossible to tell if we used just the 2.5s. Now, what is the clinical significance of that? We're trying to see if it really has something, because we're gonna do anything about it. Maybe we won't need that sequence. And finally, the tectorial membrane. I'm gonna put a little bit of emphasis in this because I do think that our latest research has identified a new biomarker that is going to be very important for prognosis of these cases. So this is a normal alar ligament tectorial membrane, and you can see a torn tectorial membrane here. It's just gone. There has to be a big hyperextension injury to happen, but what I want you to see is that huge prevertebral hematoma that we have there. So what I think is that, or the theory is that a lot of people have not paid attention that in hyperextension injuries, the biggest limitators of hyperextension are really the prevertebral muscles. So before you tear down a tectorial membrane, you have to tear down the longus capitae and the longus coli. There's no way to just do that and open them up and just get to the tectorial membrane and open it up. So when you have real injuries, even with normal tectorial membranes, if you have a huge prevertebral hematoma, you have to pay attention to it because these could be injuries that are occult and that you're not seeing. And that's kind of what we ended up seeing. So look at this injury here. This is a very low injury. Spiros, you were saying it's outside of the thecal sac. I have to review, but I definitely think this is the thecal sac right there, and the fibers are a little bit separate.
There must be a split at the
Right.
foramen where you get some PLL.
Yeah, you know how in the it must be one kind of maybe the continuation of the periosteum would be a better description, right? And this is how they look, but look at the big prevertebral hematoma. You're gonna have one of these injuries if you don't have a huge prevertebral hematoma. That's kind of the idea. And that's why we started looking at these. Huge prevertebral hematoma, complete tear of all of the four structures that we studied at the beginning. So this is completely unstable. Another injury, you're gonna see them all, they look very similar, but they all have torn the whole structure of ligaments, and you have a huge prevertebral hematoma. This is another one, a smaller one down here, but you still see the prevertebral hematoma. And you see that You have to tear all of the ligaments to get to the tectorial membrane tear. It would be very sad if we missed one of these puppies. So look at that. But the prevertebral hematoma will always guide it. So, and we kind of thought, we knew about it when we did x-rays. You know, when we were doing x-rays, you would measure the prevertebral soft tissue. I don't know if you guys don't know about x-rays, but we used to look at the prevertebral soft tissue where we're really thick. You had to suspect an injury, and we forgot about that in the CT, I guess, a little bit, and with MR, but that's why prevertebral hematomas are so important. And in kids, you have to be very careful because kids do not tear their tectorial membrane because they have kind of the periosteum of the clivus just detaches from the clivus. And what happens in hyperextension in kids is that they have these tectorial membrane clival hematomas. And you see the hematoma right there. So instead of tearing the tectorial membrane, they just peel off that periosteum from the clivus. And that happens only in kids. I guess afterwards the periosteum, and you can see it in the axle, like right there. So this has been described in the literature. I brought just an example of the literature for that, which are these distraction injuries, these hematomas. This was another paper we published in 2021 about distraction injuries in survivors and doing craniometrics. To see which of these survivors really, which were the injuries that we had to pay attention. And what we saw, there was a true association with ligamentous injuries and spinal cord injuries, with certain ligamentous injuries, with and the ones that we saw were the alar ligament, the tectorial membrane, have a high association with poor survival. So that's why we call them when we're doing this with people. So this is one of the reasons why we're including all of these in our reports now. So let's finalize with classifications, because this is the boring part. So there's so many classifications of craniocervical junction injuries. There's an absence of universal accepted system, and it's subject to formal validation. This was a paper from Greece that had tried to look for an evidence-based approach towards craniocervical junction classifications, and I saw that there were 72 described individual injury patterns. So it's impossible to know, right? So what's important about that? So the AO spine folks now have a new craniocervical injury classification, which is right here. One of the problems with the AO spine 2018 classification is they're starting to validate it. But one of the problems I really see is that most of the AO spine classifications are made to be read with CTs. They want universality, to be a universal classification of sorts. But what they end up doing in 2018 was kind of including the same injuries that we described in our paper of 2015 and put them, clumping everything together. And a lot of the injuries they put out there were ligament. So how can you classify AO spine if you don't do an MRI? It's impossible. So this is the only AO spine classification that without an MRI is impossible, because this AOI, they're looking for alar ligament tears, transverse ligament tears. So they're really looking for a bunch of ligamentous injuries, which is impossible to see if you don't have an MRI. And they have these modifiers, up to M4, that are injuries that have a high risk of non-union, injuries of significant instability, patients with factors affecting trauma or vascular injuries. So vascular injury, you need a CTA. So this is why I think craniocervical junction has to be studied with multiple imaging modalities. And we have to classify and kind of having a table like this and see what is the whole injury in order to say if it's surgical or not. So we need to really look at classifications that are valid and reproducible, that give us the severity of the injury so they can guide patient management and estimate prognosis. And that's why we've been really working on this for the last 8 years. And I think we're getting somewhere with this, right? So we did this work with our team on looking for biomarkers of prediction of outcomes for upper cervical injuries. We went back 3 years, and we saw 433 patients. And we needed patients that had CTs and MRIs with positive findings. We found 158 of them that were included. And we started to, and we just described all of the injuries that I showed. And we did a multivariate analysis to see if we could identify patterns of injury. And one of the things that we did find is that prevertebral hematomas were classified that were not described in the literature, were the most important biomarker that we could find for that. But there are 3 types of prevertebral hematomas. You can have a very thin laminar one. You can have one that's thick in the upper cervical spine, or one that's thicker in the lower cervical spine. And we kind of classified it that way to see if they correlated with injury. What we saw was that surgical intervention with patients that had prevertebral hematomas was much higher. It was almost 64.3%. And craniocervical junction dissociations with prevertebral hematomas were also very high. So of all the biomarkers and of all the stuff that is in the literature, I think we found a biomarker that is not there. We're going to work with it that really can tell you prognosis. So when you're looking at that, we're kind of going back to our roots. Looking for prevertebral hematomas is very important. So I want you guys to go back and check out prevertebral hematomas, because these can be a predictor if there's cord injury or not, or stability. One of the things that is also important is that I do not think we should be classifying craniocervical junction injuries and the rest of the cervical spine apart, because a lot of the injuries are very complex injuries of the whole cervical spine. And what we should do is understand the craniocervical junction injury, but put the subaxial spine together, because they work together functionally, and that's going to help you predict better stability. So patients with prevertebral hematoma showed higher rates of disability and greater need for surgical intervention. The prevertebral hematoma had a significant association with specific types of injuries of the subaxial spine, with discal ligamentous injuries and craniocervical dissociation. And the patients with type 2 vertebral hematomas had significant rates of craniocervical injuries. Those were the higher ones, the ones in the top, these ones in the top. So we're very glad of this paper, because this paper got awarded the best research paper for spine at the American Society of Neuroradiology this year. And we'll be publishing it together, and it's a joint effort between the departments. And these are the types of hematomas we really have to check. These are very unstable lesions. The MR doesn't look that bad, but hematoma it was a pretty unstable fracture, and you guys had to fix it because it was a very unstable lesion. So that was our conclusion for that project. The prevertebral hematoma is a promising biomarker. We have to do a prospective study. We're applying for a couple of grants to do a prospective multi-institutional study to see if other places that have high trauma centers will also have the same findings. So we went through the anatomy, we went through the craniocervical junction imaging, and we were very focused on trauma. We're the biggest trauma center in the country, so that's what we are, and we do it very well. I hope that you understood those 3 ligaments that are so important, and that we start looking at prevertebral hematomas, and we can work together to look at, biomarkers for outcomes, which is really what we want to do together. Yeah, give me a second, just to show you the whole team. So we have Dr. Bonfante, McCarty, and Timuron. These guys have left us, but Shekhar and Octavio have been great. Laura, who's our archive person, Andres and Luis, who have been in the lab, now Command and Elham, and of course, the neurosurgery team that has been working with us. So that's it. Thank you very much.
I just have 2 comments. One, I feel really bad for all the patients who got OC fusions for alar ligamentous past, because it just seems like, you guys don't do anything right. You just call it. It's tragic that happens.
Right, and in a lot of places they just want to fuse us. And what we do here, we just repeat the CT, the patient in neutral. Now, if it doesn't reduce, then we know it's for real. But we are very careful here, because otherwise we will be choosing any patient that is looking sideways as a denuding of one of the joints.
With the new scanners that we just bought, all this stuff, we can really reduce this sequence time, right? Just get like 3 volumetric, so like 2122 stir or whatever. So who's in charge of that? Sorry.
So we have a physicist that's working to really, one of the problems when you get new magnets is that
That's
you
just in
tend
brown.
to just copy paste the old protocols into the new. But we have air technology in the G and we have AI technology to reduce the scan time in the new Philips downstairs. The Siemens in the ER, we're really trying to upgrade the amount of software upgrades that we have because we don't have everything that we want. One of the biggest problems that we have, and this is a nice forum, right? We have a bunch of neurosurgeons here, is that we're doing an excessive amount of whole spines in the ER. This is ridiculous. I am doing a study of before we had the magnet and after we had the magnet and outcomes of patients, and they're the same. And we've tripled or quadrupled the amount of whole MRIs of spine that we're doing. And what happens when you do a whole spine in the MRI in the ER is that then we cannot do stroke patients, then we cannot do the real urgent patients. We have a guy 2 hours in the scanner.
That's honestly the ER. I've talked to them and they said they've actually told me that it's easier for them to order an entire spine than to examine the patient.
That's why I'm saying it's important that we have to work together because then when you say, Dr. Riascos, I have a stroke, I don't know, or I have a tumor, there's a spine there. With 2 of those spines, that's the whole night scanning 2 spines. So these guys, it's easier for them, but it's hurting our patients tremendously. If you need a cervical spine, do a cervical spine. I mean, I think you guys know where the injury is, right? That's part of the whole thing. So we have to work together to understand that they cannot be doing this all the time.
They ordered before they consult us.
Yeah.
So maybe we'll just have
We
to ask
cancel
you guys to be the only one ordering. I have to figure this out.
Yeah, we
So
cancel if we
We
catch them.
cancel a lot of them.
We cancel it, but
cancel
sometimes
it. There's
they order
very
first.
few
Same time, they
situations
can
where
get really mad when you cancel their orders and put in other stuff.
But we like that, right? We like that.
We like it.
It'd be helpful if there's a plus minus like a radiology attending or radiology attending is like, no, this can't happen unless you consult.
So that's what we want to put, we have to talk.
Because these guys shouldn't be the villains for this kind of thing, you know, like.
Yeah,
they should be
plus
attending, like-
Plus the billing is a mess, right? It's a bill.
Yeah, it's a
It
trauma
doesn't go
bill.
anywhere.
We don't make it money.
Dropped off.
No, no,
And
I
to
agree.
read a whole spine for us is half an hour as well, so we're not reading other things just because these guys just order it because there's a click out button. So in Epic, I took away the button that says whole spine.
Yeah.
Take the power away.
Thank you so much.
Take it away.